may I have the pleasure to introduce our second speaker, Dr. Andrew Wong. Dr. Wong is a very experienced infectious disease specialist currently in private practice. Before Dr. Wong engaging in private practice in 2019, he was the consultant in charge of infection control and infectious disease management of both Hospital Authority and Center for Health Protection. He is also the immediate past president of the Hong Kong Society for Infectious Disease. Dr. Wong is currently also an honorary consultant of the Princess Margaret Hospital and several private hospitals. His interests include antimicrobial therapeutics, travel medicine, HIV, and sexual health. Dr. Wong is going to enlighten us on treatment of COVID-19, especially on the use of antivirals. Without further ado, please join me to welcome Dr. Wong. Dr. Wong, please.
Thank you. Thank you very much, Ada, for your kind introduction. Can you see my slide there? Yeah.
Yes.
And yes, and thank you, the organizer, for inviting me to give this talk. And thanks also to Dr. Chen for this excellent talk on the serious spectrum of the COVID disease. And the arrival of two antivirals have sprung a lot of hope among the society and the medical community in the past month. And will they be the key players in our fight against COVID? And let's review the information about these two new medicines and highlight the important points to take note when we encounter patients that may potentially require those antivirals. So the first med that I'm going to go through is Paxlovid. Actually, it consists of two separate medications packaged together. When you take the 3-pill dose, and the two of those will be Leometravir, and the other one is Ritonavir, and it's packaged in such a way so that patients can more easily remember the AM and the PM dose. And COVID virus create proteins that are needed to build new viruses on a long string of called polyprotein. And but the polyproteins have to be chopped into smaller parts by the viral enzyme called protease in order to become active. And this is where the drug Leometravir comes into play. It blocks the virus protease from doing this job, thereby preventing the virus from completing this life cycle. And Mitravir is metabolized mainly by an enzyme called CYP3A4. And that's why co-administration of this medicine with a low dose of Ritonavir, which is have been used for HIV for many years, which is a CYP3A4 inhibitor. It will inhibit its metabolism, so it will boost the level of the Leometravir. So this Paxlovid has been evaluated in the trial and called EPIC-HR, which is an evaluation of protease inhibition for COVID-19 in high-risk patients. And this trial is a phase 2 to 3 double-blinded randomized placebo-controlled trial to look at the effect of Paxlovid in non-hospitalized patients in adults with mild to moderate disease. They have some high risk factor for progression to severe disease. And there are two ongoing other trials going on. One is a patient with standard risk, and the other is used as a post-exposure prophylaxis. So this trial recruit people above the age of 18 who were who presented within 5 days of confirmed COVID-19, and they have at least one condition which will prone them to develop severe COVID. This trial was restricted to unvaccinated persons, although the other trial which I mentioned, which is ongoing with the standard risk, include also people with vaccinated with vaccination. Enrollment into the study, which originally was planned to recruit more than 3,000 people, was stopped early due to the efficacy was demonstrated at the interim analysis. And the final enrollment and analysis was based on around 2,200 subjects. And the top panel shows the cumulative percentage of patients with COVID-19 related to hospitalization or death from any cause through day 28 among patients treated within 5 days of symptom onset. And there is a absolute around 5.5% incidence reduction related when compared to placebo. And this translates to around 88% reduction for hospitalization and death. And the result from subgroup analysis were consistent regardless of age, sex, race, BMI, baseline serology status, viral load, coexisting condition, or number of coexisting conditions. Yeah. And there were no deaths in the groups which either start treatment 3 to 5 days after symptom onset. And the relative risk reduction is even higher at 94% for patients above the age of 65 who started the treatment within 3 days' time. And treatment with Paxlovid was associated with reduction of viral load by a factor of 10 at day 5. This is consistent among patients with high or low viral load or positive or negative serology status. The incidence of adverse event that emerged during and after treatment was similar among the recipient of Paxlovid when compared to placebo. And serious adverse events include COVID-19 pneumonia, decreased renal function, and they were considered by the investigators to be unrelated to either the Paxlovid or the placebo. And treatment was stopped in some patients who comes up with COVID pneumonia or nausea or decreased renal function or decreased white cell. And adverse events were reported, and there are several of them. And one is a condition called dysgeusia, which is a problem in function of the taste. And the majority of the events were grade 1 or 2 and resolved by themselves, except one case of grade 3 dysgeusia. And the other side effects include diarrhea, hypertension, and myalgia. This is a Chinese version for informing patients in the HA guidelines. As you can see, all these have been spelled out in the guide. And Paxlovid target at an essential protein, as I've talked about, that is conserved across the coronavirus strains. And so given the very well-conserved nature of the M protease protein as the active site, and this medicine is likely to retain activities against future variants. And there has been tests among different variants, including the Omicrons, and they retain activities. And this is another study showing both Paxlovid and the one which are going to talk about, molnupiravir, are also sensitive, highly sensitive to Omicron. But we have to pay attention to one important phenomenon, which is drug interactions, because as I've talked about, actually, this medicine itself is a CYP3A inhibitor. And at the same time, it's also metabolized by this same enzyme. So we have to take note when this medicine is concomitantly administered with another medicine, which is will inhibit the metabolism of the concomitant medication. Their level will be raised. And at the same time, if we administer a medicine which inhibit or induce, especially induce the CYP3A, that may increase the clearance of the Paxlovid, making its concentration in the plasma inadequate. So it's important. So that's why we need to obtain a complete medication list from your patients, because sometimes the patient can have different doctors, and especially in the private sector, they may not have the unified record, and so it's only through information collection from the patient that we know all the medicine. And also now we have the EHR, and we can, of course, we can review the medicine in the HA. Yeah. But I would highly recommend you each time when a patient is prescribed with Paxlovid, actually for other medicine as well, to check drug interaction. And actually the FDA fact sheet, they contain 7 pages of filled with tables. I just cut and paste some of them here. As you can see, the kind of medication that there is quite wide-ranging, including antiarrhythmics and anti-cancer drugs, anticoagulants, anticonvulsants. Of course, not every medicine in a class will cause problem, but it's important to pay attention, like antidepressant, antifungal, especially people may have other concomitant disease like TB, rifampicin, rifabutin, and also statin, which is commonly prescribed. There are certain statins which are not affected, and also some health food supplements called St. John wort, okay, and also the hormone therapy for oral contraceptives, immunosuppressant, etc. So, including hypnotics, and sedative, and corticosteroid. So there are certain drugs which are absolutely contraindicated. So, for example, amiodarone, and patient who may have be on anticoagulant, rivaroxaban, etc. So you have to really check, and there are certain medications that we can use, but with caution, with monitoring. So this is a chart which is made by my colleagues in Carlin West Custos in Hospital Authority. I think they've done a very good job in trying to highlight what are the absolutely no contraindicated drugs in red, there is a RAP, this is a warfarin and rizatriptan and the oral anticoagulants, and also amiodarone, which I've talked about, and certain drugs they can use, for example, anticonvulsant, and the lady may have a very easy to remember, the LV, the lamotrigine, and the valproate, and the tripla, which can be used, okay? And for antipsychotics, there are certain that can be used. And this is, of course, this is only a general list to aid the memory. And for more details, actually, I would highly recommend you to go up to the Liverpool COVID drug interactions website, which is free, and it is super easy to use. And they have this PDF which you can download, and the red area refer to drugs that you cannot use with Paxlovid at the same time, and there are certain medicine in the red list that if you can stop the medicine for 8 days, starting from the start date of the Paxlovid administration, then you might consider using it. And there are drugs in the amber list, of which you can use, but have to check the monitoring, the side effects. And there are certain safe medicine which you can use, like ACE inhibitors, beta blockers, etc. So it will be very useful. And they also have an interactive site of which you can type in the name of the medicine. For example, I type in the Paxlovid and then check for the oral anticoagulant. And then they also, the good thing is they will also give you the reason why it's contraindicated. Okay, so you will understand better. So it's a very educational and informative, useful site that I would highly recommend. And the link is here. And then there are certain precautions for patients with renal impairment. For patients with EGFR from 30 to 60, the nalmetravir component has to be halved from 300 to 150, but the ritonavir will remain the same. And Paxlovid is not recommended for people with EGFR of less than 30. And in general, for mild to moderate hepatic impairment, there's no dosage adjustment. But for patients with severe hepatic impairment of a child C, then they have is not recommended. And for pregnancy and lactation, there's no available data for Paxlovid in pregnancy or with breastfeeding. So in general, the line for taking the Paxlovid in pregnancy is that if the benefit is higher than the risk, and then one may consider using it. And for pediatrics, there's no available clinical data for children, but this for adolescent, you may say, is over the age of 12 or above, one may use, but we have to take note the body weight requirement of 40 kilograms. And especially one thing to remember is for some frail elderly, don't assume they will weigh over 40. I just had one inpatient the other last week. We thought of prescribing Paxlovid for her, but actually should weigh only 38 kilograms or something. So she cannot be prescribed this medicine. So the other thing about, because one of the target group, I think it will be the elderly. Some of them might not be able to swallow, and they have a nasogastric tube. And this medicine actually must be swallowed whole. Okay, as you can see, is quite sizable, the tablet, and they cannot be crushed or chewed. And so this medicine, if the patient is solely on enteral feeding tube for feeding, they cannot be given to these patients. And so, in summary, Paxlovid is a very effective medication, and but it has to be given within 5 days of disease onset, and it's also quite safe. But the key things to remember is the multiple drug interactions, and one has to reduce the dose for moderate renal impairment, and it's not recommended for patients with severe renal impairment or severe hepatic impairment. So the next medicine I'm going to talk about is molnupiravir. And how does this medicine work? And actually, it's a medicine which will convert rapidly into resubsumed into the segment of the RNA of the virus, and that will masquerade as one of the key molecules in the RNA, and it gets incorporated into the strand that the virus produces. And so the virus, when they replicate, they will make errors in the copy. And over multiple rounds of copying, the medicine will force more and more mistakes until the virus is no longer able to function. And this is a phenomenon in virology called error catastrophe. And this is how it works. And this medicine is shown to suppress the viral load, and is not as effective as Paxlovid in suppressing the viral load. It's suppressed by around 2-fold compared to around 10-fold for Paxlovid, but still it suppresses the virus, and it has been evaluated in a phase 3 clinical trial called Move Out, which is a randomized placebo-controlled randomized control study, and for, again, unvaccinated adults with mild to moderate disease. And but certain group of people are not included, including patients under the age of 18 or pregnant or breastfeeding patients. And overall, there is a 3% reduction in hospitalization and death through to day 29. And so it translates to a relative risk reduction of around 30%. And there were 1 death among the treatment groups, which consists of around 700 people each arm. And in placebo group, there were 9 deaths. This effect, efficacy, is also consistent among other subgroups through the subgroup analysis. And it, as I've talked about, it will decrease the viral load very significantly with the treatment. And also, this is also sustained up to around 29 days. And it has demonstrated a good safety profile, and which is exemplified by a similar incidence of a severe adverse event, and it also has a lower risk of death in the treatment arm as far as the safety is concerned. And this is a safety profile. And so when it is indicated, and it should be taken as soon as the diagnosis is made, and preferably within 5 days of symptom onset. And it's only indicated for patients above the age of 18 or above, okay? And it's in terms of 4 capsules of 200 milligrams every 12 hourly, 2 times per day for 5 days. So if a patient misses a dose within 10 hours and of the time that it is usually taken, the patient should take it as soon as possible and resume the normal dosing schedule. And if it's missed by more than 10 hours, the patient should not take the missed dose and should take the next scheduled dose. And so this is about some online information. While the recommendation is to swallow the capsule whole, if it is not possible, and if alternative treatment is not available or suitable, and there are some procedure which is proposed in some other national guidelines, and then but of course this advice is based on preliminary data, and it should be regarded as an off-label use, and they try to constitute the medicine, and then so that it can be given through the nasogastric tube. And here is the procedure. I won't go into the details. If you are interested, you may have a look at the website to know about the how it is made. And for this medicine, there's no need to adjust the dosage with any degree of renal impairment or hepatic impairment. And there's no drug interaction which has been identified based on the limited data available. And the most common side effects include diarrhea, nausea, and dizziness. And it's not recommended during the pregnancy or breastfeeding. And if it's to be given, and it has to be, breastfeeding is to be undertaken, and one has to start 4 days after the last dose. And is not recommended for persons less than 18 years of old, 18 years age, because it may affect the bone or cartilage growth. And also there are recommendations for males in the reproductive years to practice safe contraception 3 months after one takes molnupiravir, because there might be some concerns about affecting the medicine, affecting the embryos, and so we want to be extra safe. And this is spelled out in the HA guidelines. And this medicine is also found to be effective against the variants, including Omicron. So this is the NIH recommendation for the treatment, and for Paxlovid is ranked as the first choice to use if available. And there are other treatments like monoclonal antibody or remdesivir. And molnupiravir, the recommendation will be used only if the ritonavir, the Paxlovid, or monoclonal antibody or remdesivir are available. And this is a brief comparison of the two medicines, as you can see. And so I've talked about all these, so I won't go through that in the interest of time. So so these two medicines are available. And this is the HA guideline, which was updated just last night. Okay, and for the positioning of these two medicines is position for mild symptoms, patients with mild symptoms but at risk of disease progression. And for Paxlovid is recommended as the preferred agent if not contraindicated, and the alternative will be molnupiravir. Okay. And the rationale behind is due to this higher efficacy and also the higher reduction in the viral loads. But of course, as we have talked about, one has to really look into the drug interaction, where there are sometimes if the drug can be withheld during the period of time when the Paxlovid is administered, I think it is also a possibility. But if not, for example, for some medicine, they cannot be stopped just like that. And then one has to consider molnupiravir. Okay. So this is the first version on the left-hand side. Used to be more stringent, but in the latest version, just come out like 10 days ago, is now recommended for use in patients above the age of 60, regardless of vaccination status, or if is less than 60 years old, and they have to be like with high risk factor and incomplete vaccination, or in patients with severe immunocompromised state, they can be given regardless of the vaccination status. Of course, in the clinical flow, we have to ascertain whether the patient is really like the mild to moderate grade by the oximeter. Usually the cutoff point will be around 94%. If it's above, if it's below, we might have to refer them to inpatient, especially when they are also hemodynamically unstable. So we have to consider whether patient is pregnant, breastfeeding, less than age of 18, and sexually active male with partners of childbearing potential. And if yes, and then we have to, molnupiravir would not be considered for these people. And for age of 12, above age of 12, or people with body weight of above 40, if there are no contraindication or drug interaction, and they can be prescribed Paxlovid. And it's also very important to follow up on these patients after medicine is prescribed. In the overseas, that might be done by telemedicine, which is now the hot topic in medicine, because obviously many patients might not be able to go up to the clinic, and due to various reasons. So this is something that is we need to consider. Even after medicine is prescribed, we need to monitor these patients. So I have taken the time to go through these two new oral medicine for COVID-19. And of course, it's too soon to tell whether COVID will likely develop resistance to these first generation antivirals. But the thing is, the high rate of replication is the breeding ground for mutation, and the virus is causing an acute infection, and the threat of resistance is always there, as we can see from the lessons that we learned from HIV. You know, at the beginning, we treat with the sole agent ACT, but found that subsequently the virus is very clever, and then they develop the resistance to it. And so the race for more antivirals is still on, you know, and because once we have certain resistance coming in, you know, we might need to use a combination therapy, as in the case of HIV or other viral diseases. And so that's why there are certain newer medicine which are in development, including the oral remdesivir, including a new protease inhibitor in phase 3 study in Asia, and also other like long-acting monoclonal antibodies. And hopefully, by identifying new targets for antivirals, we would have more broader pipelines to choose from when the next pandemic comes. So, so we look forward to the day when a combination of drugs, vaccines, and natural immunity will become sufficient to suppress the serious complication from the virus, so that things that presented by Dr. Chan would no longer happen. So in summary, Paxlovid and molnupiravir are both efficacious against patients with risk factors for severe complication, to decrease the hospitalization and decrease the death. And one thing to remember about always to check drug interaction for Paxlovid. And both treatments now are tested in unvaccinated high-risk individuals. But I think in real life, the important thing is to get these patients get tested. You know, sometimes they may get, you know, delayed in diagnosis, and hence cannot get the treatment on time. And resistance is always a problem to watch out for. And these antivirals would not replace vaccines, which is still the first line for defense for against COVID-19. So with that, I have also some Chinese YouTube video in case you are interested or patients want to know more in Chinese. There are separate two videos on two individual medications. So in case you have other questions for me, you are welcome to contact me via email. Okay, thank you very much.
Thank you.